Good evening, everyone. Myself, Dr. Raghu, working as a ER HOD at Yashoda Hospital, Malakpet. So, Yashoda Hospital brings every week a different concept and different talk on different aspects of the various emergencies from the very experienced faculty. So, this week we have Dr. Dilipan, an emergency physician, senior emergency physician from KMCH Hospital, Coimbatore. So Dr. Dilipan will be talking about cardiac pacing in ER or cardiac pacemaker in ER. So we all know how important is cardiac pacing or cardiac pacemaker in ER. So where we have the 4 cardiac arrests which are non-shockable and shockable. So in the non-shockable, when the PEA, so this comes into play for us. So, Dr. Dilipan?
Yes, sir.
Yeah, now you can go ahead.
Sure. Okay. Hi, good evening. Myself, Dr. Dilipan, working as a consultant in KMCH Korea Medical Center. It is based in Coimbatore. So we have 60-bed emergency department. So we are running this for last 15 years. We have 10 consultants, for we have 6 MEM seats per year, for we have 3 MD emergency medicine, which has been approved this year. It has been like we have corporate plus medical college. So I'd like to thank the SEMI board for choosing me or giving me today the session. Special thanks to Dr. Saujanya ma'am, who has like identified me, and she asked me, like, she gave me the preference, like, what are the topic you need to speak, like, you can speak. So thank you, ma'am. Thank you for that. Thank you, everyone. And for the listeners, I would like to say a few points before starting the topic, because the importance of starting this topic is like cardiac pacing is always a gray area where most of the people will not touch it, because it's like the patient, those are coming with an cardiac pacing, mostly they'll die with us like maximum duration of like 1 hour, and it's more of a theory part. So what I did for today's my presentation contains 70 slides today. So the topic which I'm going to speak is like about 25 minutes and 5 minutes for the presentation. I have placed 3 case scenarios. So one thing I'll be speaking about the cardiac pacing. Remaining 2 case scenarios, I will be speaking about the recent advanced techniques or recent advanced procedures which can be done in ER. Okay. So I'll start my topic. So go with my topic. Okay. So this is the first case scenario. So a 45 years old male brought to an ER with consumption of the plant poisoning. On arrival to the ER, the patient was drowsy, heart rate of 25 per minute, and BP of 60/40. As we all know, because we work near to the Western Ghats, because this type of poisoning, when I used to work in Chennai, this type of poisoning was not common. But since we work near close to many villages, this is called as an Oleander poisoning. Yes, this is one of the cardiac toxicity. It's more of in cardiac surgery. Usually the patient presentation, if they consume a plant, they will go for the bradycardia. Mostly because of the hypotension, they will go for death. If the patient is going to present to here within half an hour or 45 minutes of the time period, usually we'll go with the conventional method. We'll go by an ABCD approach. The patient is hemodynamic is unstable. Yes, we'll take care of the airway, breathing, circulation part. So all the conventional method was did for the same patient. This was the ECG. This is more often sinus bradycardia. No, yes, as an emergency physician, the first and foremost thing what we try to do is always give an atropine to increase the heart rate. Next, if the patient has a circulatory problem, always we start with an adrenaline, like we'll go for like noradrenaline or vasopressin. So all this like triple inotropic support will start, and in case if the patient is not responding, in case of cardiac toxicity, always we can go for temporary pacemaker. So this is what we always do in ER. So we all know this is what can be done in ER. So same case presentation, I like to discuss in other way, the next case scenario. So this case scenario, I would like to focus more on theory part. So what is facing and how it works and what are the methods and what are the functions and what are the, how to troubleshoot it. This will be this is what I will be speaking for next 10 to 15 minutes, more focused on the theory basis. Next, I will go for the practical part. Okay. So going for the outline of the presentation today, like introduction to the cardiac pacemaker, what is the definition? And clinical indication, pacemaker design, pacemaker function, and types of pacing, and what is the patient education we are going to give. And first slide, you need to know what is the definition of cardiac pacing. So the definition of a cardiac pacing, it is an electrical device that delivers direct electrical stimulation to stimulate the myocardium to depolarize and initiating a mechanical contraction. As we all know, what is depolarize, what is repolarize and plateau phase. So it isn't just, to make it simple, it isn't just an electrical device which is going to deliver some amount of like electrical stimulation to the heart, which is going to get contract. So this is what that meaning to simplify the definition. Okay. And the clinical indication, as we all know, this is symptomatic bradycardia, symptomatic heart block, second degree heart block or complete heart block, and bifascicular, trifascicular bundle branch block, and prophylaxis. The prophylaxis, which means it is a vast area where we use it for like cardiac toxicity, beta blocker toxicity. And many people, they doesn't know, because we work near to the Western Ghats, as I said, like there is something called winter greenwood oil. So when many people they come for Ooty trip, you can see the eucalyptus oil which they use it for like joint pains and all. Even that is more often lethal dose. And we have reported case of like 5 to 6 from the Ooty military hospitals where no one has survived. So that is called as winter green oil. And like as I said, like oleander poisoning, and there is something called glorious superba. This all comes in conditions of like cardiac toxicity where they need a prophylactic or they need an emergency temporary pacemaker can be done. Okay. So many people they doesn't know how the pacemaker functions, or like how the pacemaker is like functioning. So before going to the core topic, many people, you need to understand what is the pacemaker design. So here you have two parts. If you see, so there is something called pulse generator. Next is called as an lease. So here you see this is called as a pulse generator. Okay, this is called actually the machine which is going to deliver or which is going to stimulate the electrical current, and the leads which is going to go and deliver to the, either it is going to deliver to the right atrium or it is going to be delivered to the left ventricle, or it can be biphasic also. Okay, so the pulse generator, it has three types. One is like many people we see, or like we see from the cardiac patients who have a permanent pacemaker, who always encapsulate in a metal scan over the skin, it will be covered. And next one is called as a temporary pacemaker, who they'll be hanging like a sling back. They'll be wearing it and they use it for temporary pacemaker. In case if you want to discharge the patient, or like if they need for a temporary purpose, still the patient needs of a permanent pacemaker, this can be used. And next, the most common thing we use in our department is like defibrillator. So in defibrillator is always connected. It has been converted to a temporary pacemaker because we have like pacing functions too. So these are the pulse. This is called as a pacemaker design. As I said, the pacemaker design is two things. One is like pulse generator and a leads. Pulse generator to tell you thing. One is like metal can, like a permanent pacemaker. Temporary. Next one is a defibrillator. And when it comes for the lead, there are two types. One is like it's called as a unipolar lead. Other way it is called as a bipolar leads. So unipolar leads is usually placed either if the patient has a problem with the atrium or if the patient has a problem with the ventricle. So it will be placed, and then the electrical stimulation will be given. So that will be sensing and pacing the chamber. So if you see this X-ray, see this is like, as I said, this is a pacemaker, permanent pacemaker, which is kept for the patient. From there, where you can see a single lead, it is attached to the left ventricle. Okay, you can see the ventricle. So this is called a single polar, or it is called a unipolar lead. And there is something called dual chamber. The patient has a problem with the atrium and plus the ventricle. Yes, you can place like dual chamber. So in this case, if you see, there are three leads. So three leads is very uncommon. Usually they won't keep it unless and until the patient is having like bifascicular block. So I didn't put the X-ray of like bipolar leads, but this is a concept where you can see the pacemaker design. You have like three leads, which is going for the atrium, and one for the right ventricle and for the left ventricle. In case it is going to be two, it will be either by the atrium or a ventricle, or it can be in both the ventricles too. Okay. Next, coming for the as we finish the pacemaker design, as we come for the pacemaker function, the pacemaker function has like three things. One is like pacing function. Next one is sensing function. Next one is capture function. This is the most important. All the postgraduates should know, because the once the pacemaker designs go, this part comes to our where we are going to intervene for the patient. So what is pacing function? So pacing function is as soon as you take the ECG, we can identify whether the patient is having like contraction or like contractile problem with the atrium or contractile problem with the ventricle, or the patient with comes with a permanent pacemaker have like if the pacemaker is not functioning, you can always look for the pacing spikes. If the patient has like atrial pacing, if the atrial pacing is missing, then you can always troubleshoot the pacemaker is not functioning because of some other reason. Okay. So pacing function, yes, you can always keep it in two things. One is atrial pacing, next one is ventricular pacing. So how to identify by an ECG whether this patient is having atrial pacing or ventricular pacing? Always you look for the pacing spikes before. If it is lies before the P wave, it is always an atrial pacing. If it is lies before the QRS, it is always ventricular pacing. Okay. If you have the pacing spikes before the P wave and the QRS, the patient is having like atrial pacing and as well as the ventricular pacing. This is how we classify. Okay. So this is what the pacing function. Next, we come for the sensing function. The sensing function is like ability of the cardiac pacemaker to see the intrinsic cardiac activity when it occurs. Okay. So the sensing function is basically classified into three categories. One is a demand, next one is fixed, next one is trigger. But when you come to an ER, always we suggest, or like many recent advanced paper shows, always better to fix the function or better to fix the pacemaker, the temporary pacemaker, to keep it in a demand mode. Don't keep it as always place it in a fixed mode, because the demand mode and the triggered mode, sometimes the volume or like patient output, cardiac output might be differ. So many studies says if you're going to, because when the patient is having severe LV dysfunction, you doesn't know how much of the heart is going to pump out the blood. So many people, what we try to keep it in a demand mode or the triggered mode. Example, the heart rate, we keep it in a demand mode, like as a heart rate is 60, but the cardiac output is like, example, the heart is only ejecting a 90 ml. Many recent advance say out of 10 people, 3 people are getting stroke when you keep it as a demand mode or triggered mode when they come from acute phase. But in case it is going to be a chronic phase, that is different. But in emergency setup, it's always better to keep a fixed rate. And the heart rate to be expected in case of severe LV dysfunction is always better to keep it higher. In case of moderate LV dysfunction, is always better to keep it from 60 to 70. Because the concept is once patients having severe LV dysfunction, the blood which is going to come from that is going to be decreased. So what we are trying to do, indirectly you are going to increase the heart rate to increase the blood flow. In case of moderate LV dysfunction, it is better to keep the heart rate is like from the 60 to 70 to the fixed, so that the sufficient amount of blood is sufficient. Okay. To elaborate demand more, the pacing stimulation is delivered only if the heart rate falls below the present level. And the fix, so whatever the reason, even the heart rate, you just keep it as 80, you fix the heart rate as 80. Even the heart rate is like all the patient heart rate is like pumping at 20, you don't mind. It is always try to deliver the patient like out of 80. So that even the heart rate is between 20, it will calculate, it doesn't calculate accordingly. It will always try to deliver the electrical stimulation, whatever the pacemaker is feeling. Trigger mode is always deliver the stimuli in response to sensing the cardiac event. These are the three types, but always as per the ER consultants, it's better to keep it in a fixed mode, not in the demand mode, unless and until you know the patient status. Next comes for capture function, because once we keep the settings, as soon as you come, you identify the problem of the patient, whether the patient is having atrial dysfunction or ventricular dysfunction. Then once you identify, you're trying to put the pacemaker and you're trying to keep it in a demand mode or fixed mode. So once you keep this thing, you need to always troubleshoot whether the pacemaker which you initiated is functioning or not, or it is useful for the patient or not. So that always we call it a capture function. So capture function, we basically classify into two things. One is an electrical capture, next one is a mechanical capture. So electrical capture, yes, once you initiate the pacemaker, always you need to see the ECG, whether the heart rate is improved or not. The ECG has like heart rate, in case, as I told, like we initiate for the symptomatic bradycardia, the heart rate is 40. You kept in a fixed mode of heart rate with a 70. Once you keep the heart rate start to function, you need to see it in the ECG, the heart rate should come for the 70. And the mechanical capture is, as we discussed this case a little earlier, I told the BP of 60/40 and the patient is not responding for any of the inotropes. So once the pacemaker started functioning, the BP should come for the normalize, at least it should improve. So that is what it's called as an electrical capture and mechanical capture. Okay. And the pacing types, as we all know, it's a permanent and temporary and biventricular. The permanent pacemaker usually it is treated for chronic heart conditions, and that you need to take the patient for the cath lab and you need to do locally. So that usually it will be done by cardiac. Okay, this is what the image of the permanent pacemaker. And next, the temporary pacemaker. The temporary pacemaker, yes, we use like one. It can be used as an intravenous, or it can be used as a transcutaneous pacing. So most of the year we try to use in transcutaneous basing. Some people know what they say when it comes for like toxins, like as I said, like winter greenwood oil or Oleander. Some people are not responding for the transcutaneous because the amount of the electricity which is developed, it has very low impact to the because it need to pass through the skin, and it always have like your when you have a patient is like little obese or you have like more of muscle mass, it is not creating that much very good impact as what like intravenous is creating. So many people in case of emergency procedure, if the patient is crashing, they prefer now they started once you put a transcutaneous, they are preferring to go for transvenous pacing. So that is also important. And next one is also biventricular pacing. This is used in severe heart failure, which we don't do it in ER, but for the knowledge purpose, we need to know. Okay. And the incision side is like left subclavian and the internal jugular is mostly preferred because that's which is very close to that. And the chance of and we prefer is better to go for the left subclavian. The most one thing, the complication you might expect is like pneumothorax, but you need to be a little careful about it. Okay. And the patient education, always you need to teach the patient like how to troubleshoot, and we always give them brief orientation about the pacemaker, how your temporary pacemaker is going to work. In case you have any syncope or dizziness, or you have like profuse sweating, any of the thing you need to report to emergency department. And in case many people with a permanent pacemaker, we give them education to always check for the pulse in a week. At least you need to record it. Or nowadays, even many studies, they are saying like if you have a good Apple Watch, you can even record your pulse and like heart rate, and you can send the ECG to your consultants. Even that can be done nowadays. Okay. So to come to an conclusion about the pacemaker, so as of you things we need to know about the pacemaker is like what are the pacemaker designs, how the pacemaker is going to function, and what are the three types of modes which we are going to give like fixed, demand, and trigger. Next, you need to always know the capture function, how the electrical and mechanical capture is going to work, and how to troubleshoot these things, and how the ECG spikes is going to work. As for the pacemaker is like concern, this is what more of a theory part. And the history, the world's first pacemaker was invented in the US in 1932, and the first commercial pacemaker, which comes with the Medtronic, which comes in 1960 for the normal commercial purpose. With this, my first case scenario has been over. I'd like to tell like which is few more things which we didn't know here. So as I said, we lie near to like ours is one of the corporate setup, which is like many of the primary healthcare is like we have been associated with many primary healthcare and we receive about the like many people doesn't know about the aluminum phosphate poisoning. We call it as Selfos poisoning. Before 2022, in any patient those who conceive two tablets of aluminum phosphate poisoning, we always tell we can't do anything because the patient is like it has like 99.9% of the mortality. But in recent days, when after the 2022, when we change the modality of the treatment, the patient outcome has improved. So that is what I'm trying to present for this case. A 45-year-old male came with consumption of like Selfos poisoning, which is 4 in number. On arrival, the airway was patent. As well, like breathing, bilateral air entry was good, no added sounds. Respiratory rate is 30, saturation shows 80% on the room air. Circulation fast, central pulse is felt, peripheral pulse is not peripheral pulse was not palpable, with a heart rate of 126 per minute and 70 heart rate BP of 70 query. And the patient was conscious oriented but agitated. Pupils were bilateral 2 mm reacting to light. With this, we proceed with an intubation. Because of the hemodynamic instability, we intubate the patient, and already the attendants brought the tablets which show an aluminum phosphate poisoning. Otherwise, it calls Selfos poisoning. The lethal dose of aluminum phosphate poisoning is like half of the tablet. Okay, usually they keep it for the coconut tree for the for insect
fails to come forward
Okay, and we took an ABG.
will
ABG
be
showed severe
treated
metabolic acidosis. And for stabilization, we started on oxygen support, fluid resuscitation, and inotropic support was started. This is all the conventional method till 2022. We are following ABCD protocol, inotropic support. If the patient and severe acidosis, we try to treat the acidosis. Some people will try to take for the dialysis if the patient presentation is little earlier. But even though we have about like 25 patients per year with comes with an aluminum phosphate poisoning, till 2022, either the patient has consumed less than the lethal dose, or the patient who are present to the ER, out of 100, only 3 has survived in 2022. Then we changed, okay, because once we started losing, then we thought like, okay, we try to initiate the ECMO. ECMO can be initiated in ICU. From 2022 to 2000, mid of 23, we try to initiate the patient. As soon as the patient comes to an ER, we try to intubate, we put central and arterial, we try to shift for an ICU. The ECMO has been initiated. Even that has given only 10% of the success rate. Then we change the line of management by initiating ECMO. In case of any refractory hypotension or severe metabolic acidosis, we try to initiate the ECMO in emergency itself. Then the patient survival rate has increased up to 75%. From 2023 from June to 2025 June, we have initiated more than 46 ECMOs for aluminum phosphide poisoning. And the patient had out of 46, 32 has survived, which has like 67% of the success rate. And we choose the patient very wisely, because we can't, if the patient has a lot of comos or the patient comes with severe acidosis already with a triple inotropic support, it shows very negative success rate. So always we try to initiate the ECMO in ER who was going for metabolic acidosis, or the patient is going for refractory hypertension. Before the patient started having a refractory hypertension, we try to initiate the ECMO. The patient has a very good outcome. These are the few pictures of the ECMO which we do it in ER. So many people think that once we ECMO, we call for the CTUS team and for the anesthesia team that they will be doing. But here, like we initiate the ECMO, we'll put the line, we'll dilate, we'll call for the perfusionist. First, for the 10 cases, we had a help of the CTUS team. Now the CTUS team has like, okay, once they think we are capable, we are trying to do all, like last 30 ECMOs, we are trying to do it alone. In case of we need any help, but we'll do it by the CTUS. Out of this, as I said, like 47, 33 as survey. These are the few pictures. And this, as this patient, when comes, we do an AV ECMO in ER, arterial venous ECMO. When we are trying to initiate for the ECPR concept, but still we don't have enough amount of data to publish or to have a success rate to present in a forum. But this for an aluminum phosphide poisoning, the ECMO has like very good outcome. And even we try to, when we're trying to initiate like in emergency, we need to have like few complications, like because we can't fumigate the ER. So one thing is like infection, and out of 33, 3 has lost the limb because of the perfusion and the ECMO related complication. They have went for an amputation, but they have survived. This is all like one of the complications of the ECMOs when we try to do it in ER. But this patient, as the 4th day we try to decannulate, and the 5th day patient has extubated and the patient has walked away home stable. The patient has after 2 weeks, he's like conscious oriented, he's walked away home, he was perfect. And this, regarding this ECMO, we have published many articles in like British Emergency Journal, and followed by we have like 4 international journals and 18 journals which has been published in like national journals. And we are trying to do it still today also. We have an ECMO and trying to do it in here, which has good outcome. Next, yes, we are trying to initiate this as a concept of ECPR concept. That's the ECPR program which is going on over here. The problem is like the time duration which we try to put time duration to put an ECMO. It's all minimum we need at least 30 to 35 minutes. But the duration of the resuscitation maximum, if the patient is not responding, or if the patient is going for refractory cardiac arrest, we find it's very difficult to do an ECMO during the ECPR. So that is what we are working on. And the last case scenarios, this is a traumatic bleeder. As we all know, because when it comes for circulation clot, many people we face a run over injury. Example, we got a patient. He's a 65-year-old male brought an emergency which a lorry has run over. He got a crush injury over the right left lower limb, followed by right femoral artery. He has like active extravasation. Initially, any vascular injury, we try to give a tourniquet, or we give a compression, and we try to shift the patient for the immediately for the theater. But in this case of scenario, when you have a patient with a crush injury where your pelvis is shattered, the patient BP is of 60/40, even if you're going to do a like massive blood transfusion protocol, you give him, if you give like more amount of blood, even when you couldn't clamp the femoral artery, or like when you couldn't control the bleeding, where the source of bleeding, and the patient is going to die before shifting for the theater. For the practical speaking, even in tertiary hospital, if you receive a trauma case which comes with an arterial injury, definitely it is going to take like 15 to 20 minutes to shift him for the theater and to the vascular surgery to come and intervene. But in this case, even we were losing the patients till 2021. We are also losing the patient because we try to do all the things. Even the patient, by the time when we try to shift for the patient is already comatose, or the patient so almost he lost all the blood. So then we thought of putting a bulldog mosquito for clamping, that was not very excellent. Only in few case scenarios where it is a clear cut or like industrial accident, it was good. When it comes to the crash injury or like road traffic accident, we find it very difficult. So what we did is, like, when we had a discussion about this case in our hospital forum, why don't we try REBOA for this type of patients? Then we have tried REBOA by an ER. We tried for this patient after I had a lot of discussion before, because of many previous experience of the trauma patients. Then we had all the catheter. We thought like, okay, we'll try to do it in ER. So in this patient, yes, we initiate the REBOA, where it's very easy. Like you can always, like, you can just like put in artery line, you can just insert the REBOA. Always it's safer till, as an emergency patient, we find it very safer to go till the zone 3, because zone 1 and 2 we need like proper experience, or like, because once you go little bit here, you will affect the cardiac output. Always up to the zone 3 is always a safer zone, which what we feel. Once you inflate the balloon, aortic balloon pump, the bleeding process is going to come for the nil. And in the meantime, always you can just like give one like you can always increase the intravascular fluid by giving a massive blood transfusions. Always the patient will attain the hemostasis. Then you can shift him for the theater, so that even the vascular surgeons or the CTV surgeons can get a like time period where they can react for it. So this case I thought of presenting in this forum. These are the few images which was taken. Thank you for everyone for giving me the opportunity. I know since the cardiac pacemaker is a little bit of dry topic, so I thought of putting theory. And this last two cases, I thought of bringing to this forum is like, because many emergency vision, we always try to limit our like procedures with an intubation, central line, and arterial line. We don't go dialysis line. We don't go beyond for that, because we always think that is belongs to critical care, or like we. So these all we didn't start it as very easy. We had a lot of struggles. Even we went for the ECMO courses to get a proper recognition and proper like techniques to be followed. With that, we are able to do these things. And I leave this to the open forum, because like many seniors are attending this meeting. I like to get like from the opinions from them also. Thank you. Thank you for that.
Yeah, Dilipan, this is Dr. Raghu.
Hi, sir. Hi, sir.
Yeah, there's a nice presentation of varying topics. One is on the Oleander seed, where the patient has present with complete heart block, where you have done the transcutaneous spacing. Then one, the aluminum phosphide or Selfos, where the patient has unstable hemodynamics. So you have initiated the ECMO in the ER. And the third one is the bleeder patient with the femoral artery bleeding. So where the patient has unstable hemodynamics, you have initiated the REBOA. So at Kova Medical Center, you were having a different experience with all the latest gadgets. So because many of the ERs, they might not be doing the ECMO and REBOA, they are confining to the transcutaneous spacing, yes.
Yes.
And for the audience sake, can you tell anything about the pacemaker malfunction, pacemaker related complications, or pacemaker related arrhythmias?
Okay, sir. Sir, pacemaker related arrhythmias is like, sir, one problem where we find with the transcutaneous spacing is like, so when you keep so in case if you're putting the patient in a demand mode and you keep the frequency of like 25, 35, so many people with the toxic, when they present with a toxic background, when you keep a less frequency, they'll respond very good. But we always we don't troubleshoot the defibrillator, because we keep like We doesn't know what threshold the patient will be responding. Many people try to keep like 45 electrical voltage. So that is going to cause this permanent scarring for the patient that might trigger the arrhythmia too. So the most common arrhythmia which you can, because of that pacemaker induced, is like you can have like bigeminy. So that is the one problem we always face it. So what is my suggestion in case of patients having a severe LV dysfunction? Always is better to go with a more amount of the voltage. If the patient comes with an acute scenario, it's always better to go with a less voltage, where you can always go for the mechanical capture, because you have a, now many people are using NIBP, and many people are using arterial BP also. As soon as the patient comes, they secure it. So always you can try to start with 35. You see whether the patient is responding for 35, or if it's not responding, you go for the 40, 45. Because all the defibrillator, the pacemaker which we have it in ER, always it increases by the 5, not by like a single digit or the double digit. Always it increases by the 5. So it's better to decrease. You always try to maintain the patient with a less frequency to have a good cardiac output. If you increase the more amount of the cardiac output, then it is going to be the trouble for the patient, which is going to have a permanent scarring, and the patient will have like multiple bigemies the patient might face. So that's one advice which I try to give it.
So regarding the pacemaker, any patient who has been initiated the pacemaker and they may come to the ER with syncope, giddiness again. So the problem we might be seeing the failure to sense, failure to pace, failure to capture, or there may be a oversensing. So these are the some common presentations where the patient can present to the ER post pacemaking. And the other pacemaker related complications.
The pacemaker, usually the permanent pacemaker, the problem is will be a chronic. It will not be an acute case scenario, sir. But if the patient is going for the transvenous with a temporary pacemaker where they'll hang it like a sling bag, it might be like a catheter. Sometimes the catheter might be pulled off, sir. So when they're like, it's like more often like dialysis line or like internal jugular line, where the patient when they're trying to sleep, or they might be pulled off, or even when they doesn't know what settings they kept, they might keep it like if the most of the temporary pacemaker, if you're shifting for the home, it will be kept in a triggered mode, or it will be kept in a demand mode. It will not be kept in a fixed mode, sir. Some people, when they're trying to change, when they're trying to pull it out, then the patient will come with a syncope. Then we find it very difficult for putting a patient with a transcutaneous, where even your transvenous pacing will not work in the case of scenario, sir. Even for the permanent maker, if the patient comes with a permanent pacemaker failure, when you try to apply a transcutaneous pacing, most of the time the transcutaneous pacing is not going to function, sir. You always need a cardiologist for the backup to support it, sir. But as of now, we didn't face these things. But it's always better to avoid the transvenous pacing to send home, or to be always intervening in the cardiac cath lab, sir, not in the emergency department, because we have lost many patients when you're trying to troubleshoot it.
So what is the incidence of infections you are seeing in these patients? Infections.
The chronic patients we don't see. For the permanent pacemaker, because they all be lying in hospital for 3 days, they'll be getting IV antibiotic, then you'll be discharged. In the intravenous, yes, out of 10, 1 will be getting an infection, sir. It's a local site infection where we used to take culture, and we put them in oral antibiotic. With a time or 4, they used to settle down very good. Only few people they go for like infective endocarditis. Very, very few, sir. Very few.
So what is the incidence of hemo and pneumothorax in these patients?
Sir, we don't initiate intravenous, so I don't have that backup, sir.
And any briefing about pacemaker syndrome?
Pacemaker syndrome, no, sir, no idea, sir.
Okay. So that was nice speaking to you, Dilipan. So you have a good experience in the year about regarding your pacing, ECMOs and REBOA. I'll see if there is any questions from the audience. So there are no questions from the audience. If there are no questions from the audience, so there is any role of the magnet in the ER for these patients coming to the ER after permanent pacemaker implant?
Magnet, sir. So we
Yeah.
have because the problem we find it like when you're shifting for the MRI, sir. So that is what. So all after like there is a study after the 2016, all the pacemaker which is all for MRI compatible. The patient those who have been placed before 2016, then we might have a problem for shifting for MRI, sir. So the normal screening, we have like pacemaker screening, which is a hand device, which before all the patient or like, it's like more of a metal detector. We always check with that whether the patient is competent for the MRI or not, sir. With that thing, we'll try to screen and we'll try to shift the patient.
Okay,
for
so
MRI.
most of the patients you are doing a transcutaneous pacing and shifting to the cath lab for the transvenous.
Yes, sir.
Yeah. So, okay, Dilipan, if there are no questions, we'll then wind up.
Okay. Thank you, sir. Thank you. Thank you for the opportunity, sir.
And I would have been more happy you could have stressed more on these pacemaker only, like the permanent pacemaker more in depth. As we are doing the transcutaneous in the ER in detail, and the transvenous, some residents may get the opportunity if they're working in the cardiology postings.
Yes, sir.
So if the cardiologist is kind enough, they help our residents to get exposed to this. And permanent pacemaker, it is a complete cardiologist thing. So where they will be doing by themselves. And the other thing, ECMO, which is now a growing thing, the ECPR, some centers, they are initiating these new things.
Yes, sir.
So for the hope so in the 2025, the next guidelines, what will be the role of ECPR bar ECMO? And REBOA again, it's a different topic again. There are the positives and the negatives when initiating except because we go up to the zone 3 only. So to go
Yes,
into
sir.
the zone 2 and zone 1, we should have that expertise in that part.
Yes,
So
sir.
up to the zone 3, we can go and we can negotiate there.
Yes.
So Dilipan, that was nice talking to you, and it is a good insights for all the residents and all the ER physicians. So if there's no
Thank you.
thing, we will wind off.
Sure, sir. Thank you, sir. Thank you so much.
Yeah, I thank Yashoda Hospital for bringing up a different topic every week with an expertise in the fields of emergency physicians. So we are organizing with this with the semi and by so for the knowledge of all the ER physicians.
Thank
So
you,
if there
sir.
are no
Thank you so much.
questions, we'll wind off. Thank you and good night.
Thank you, sir.
Yeah.